Welcome to the deep dive. Today we're strapping in for a really high-stakes look at a class of drugs that operates right on the razor's edge of human physiology.
We are.
Cholinergic agonists. I mean, we're essentially talking about chemicals that force your entire body into rest and digest mode.
And understanding the clinical implications of that
Yeah.
is, well, it's absolutely vital.
So that's the mission for today.
That's our mission today, yeah. We're distilling the core pharmacology of these powerful agents. We need to understand their mechanisms, their uses in conditions like myasthenia gravis, for instance, and Alzheimer's disease.
And the safety protocols.
And critically, the safety protocols needed to manage them. I mean, if you're dealing with the parasympathetic nervous system, the PNS, you're dealing with heart rate, blood pressure, muscle movement, cognition, the margins for error are just razor thin.
So let's define the players. We have cholinergic agonists.
Right.
These are drugs that they respond to and stimulate the receptor sites for the neurotransmitter acetylcholine, or ASHE.
And because that stimulation mimics the PNS, they often get another name.
Parasympathomimetic drugs.
Exactly.
So what are the clinical signs you should instantly associate with that name?
You should think of all the effects tied to relaxation and energy conservation. So a slowed heart rate bradycardia, decreased blood pressure, a huge increase in gastrointestinal activity, and pupil constriction. We call that miosis. You should immediately just visualize the whole system sort of slowing down and becoming more active internally.
The one thing keeping that whole system from just going into overload is an enzyme.
Acetylcholinesterase.
Right.
Precisely. That enzyme is the body's natural safety brake. Its entire job is to instantly break down estradiol after it's done its job. It prevents massive, dangerous overstimulation.
And our sources really emphasize that this is the core challenge of the entire drug class.
It is, because these drugs stimulate the entire parasympathetic system. Limiting their action to just one area, like just the eye or just the bladder, is extremely difficult. And that's why we see such widespread systemic adverse effects.
That difficulty leads us right into the two different ways these agonists work. We have direct and indirect.
Yep.
What's the fundamental difference in how they approach that receptor site?
Well, the direct-acting cholinergic agonists are, you could say, molecular imposters. They're built almost identically to ASHE itself.
So they just fit right in.
They walk right up to the receptor sites, mostly the muscarinic ones on the effector cells, and react directly with them. It causes immediate stimulation. It's a direct activation.
Okay, so that's the direct route. The indirect actors, they take a much sneakier approach.
They do. The indirect-acting cholinergic agonists, some people call them anticholinesterase inhibitors. They never actually touch the receptor.
So what do?
Instead, they react chemically with that critical safety enzyme, acetylcholinesterase, and they just inhibit its function, either temporarily or, in some cases, permanently.
That seems like a totally different mechanism. What's the clinical result of blocking the breakdown enzyme?
It creates a traffic jam, a buildup. The natural ACA that's released by the nerve, it just stays in the synaptic cleft for much longer.
So it accumulates.
It accumulates, and that increased concentration causes prolonged amplified stimulation of the receptors. So you get the agonist effect, but indirectly.
Let's focus on the direct actors for a minute. Since they cause these big systemic issues, the sources say their use is a bit limited today. Where are they still useful?
Their systemic uses are really focused on smooth muscle activation. So they're used to increase bladder tone, increase urinary output, specifically for non-obstructive urinary retention, like after surgery or childbirth.
And in the GI tract?
Same idea. They're used to increase GI secretions and general activity.
What about for ophthalmology?
This is a great example of getting specificity by just focusing the drug locally. You apply it topically as an eye drop, and it induces miosis.
Pupil constriction.
Right, pupil constriction. That opens up the angle in the eye, and it relieves the pressure you see in glaucoma. And because it's topical, systemic absorption is minimal. You avoid most of those nasty cardiac and GI effects.
The prototype drug here is bethanechol. Why is that one so often chosen for bladder issues?
Bethanechol has a really strong affinity for the cholinergic receptors that are specifically in the urinary bladder, so it's great for neurogenic bladder atony and that non-obstructive retention.
And it has a longer effect.
That's the key. Unlike natural ataria, bethanechol is not destroyed by acetylcholinesterase, so that gives it a much longer, more therapeutic duration of action.
What about other direct actors?
Well, we also use drugs like cevimeline and pilocarpine. They're used to stimulate secretions to relieve that debilitating dry mouth you see in conditions like Sjögren's syndrome.
Okay, looking at the adverse effects, I mean, if we're forcing the entire parasympathetic system into overdrive, what are the red flags we need to be watching for?
You should be picturing figure 32.2 from the source material. The cardiac risks are severe. We're monitoring for bradycardia, for heart block, significant hypotension,
Even cardiac arrest.
even cardiac arrest, yes. And for the GI system, you have to anticipate nausea, vomiting, intense abdominal cramps, diarrhea, excessive salivation, and even involuntary defecation.
And dehydration becomes a real risk then.
A huge risk. You have to manage that proactively.
So that means the contraindications are pretty straightforward. It's
Yeah.
basically anything that would be aggravated by more PNS activity.
Exactly. We avoid these drugs in anyone who already has bradycardia, low blood pressure, or something like a peptic ulcer where more acid would be dangerous. And critically, anyone with an intestinal or bladder obstruction or asthma,
Why asthma?
because these drugs cause bronchoconstriction. You could trigger a dangerous asthma attack.
Let's shift gears to the indirect actors, the acetylcholinesterase inhibitors. Before we even get to the therapeutic uses, we have to talk about the devastating power they represent.
Absolutely. This category contains some of the most toxic compounds known to man. I'm talking about the irreversible acetylcholinesterase inhibitors,
Nerve gas.
infamously developed as nerve gas agents. When it's used as a weapon, it permanently binds to and deactivates acetylcholinesterase.
And the result is?
A massive, overwhelming cholinergic crisis. The AC accumulation is fatal. It causes prolonged, uncontrollable muscle contraction, which paralyzes the diaphragm, and the person stops breathing.
It really highlights the sheer chemical power we're dealing with. But thankfully, there's a life-saving protocol for this kind of exposure.
Yes, for nerve gas and also for severe organophosphate pesticide poisoning. The protocol is crucial, and it involves two drugs.
What's the first one?
The primary antidote is pralidoxim. Pralidoxim works by physically reactivating the acetylcholinesterase enzyme. It essentially frees it up to start working again.
And that's mostly for the peripheral effects, right? What about the brain?
For the central nervous system effects, pralidoxime is used with atropine. Atropine is a cholinergic antagonist. It blocks the receptors.
And it crosses the blood-brain barrier.
It does. So pralidoxime reactivates the enzyme, and atropine immediately blocks the receptors to give symptom relief and block that CNS toxicity. It's a non-negotiable combination in that kind of overdose.
Understanding that toxic power really gives context for their therapeutic use. So how are these reversible indirect agonists used to treat a disease like myasthenia gravis?
Myasthenia gravis, or MG, it's an autoimmune catastrophe at the cellular level. The body creates antibodies that destroy the ACE8 receptor sites at the neuromuscular junction.
Where the nerve tells the muscle what to do.
Exactly. Fewer receptors means you get progressive muscle weakness, and that can threaten the diaphragm and respiration.
So if you can't replace the receptors, you have to make every last molecule of ACE8 work harder and longer.
That's the strategy. We use inhibitors like neostigmine, pyridostigmine, and edrophonium. The key feature here is that these drugs do not readily cross the blood-brain barrier, so their action is focused almost entirely on the neuromuscular junction to maximize muscle strength.
And this brings us to what might be the ultimate clinical challenge, distinguishing between a myasthenic crisis and a cholinergic crisis.
It's a huge challenge, both present with severe muscle weakness and respiratory distress.
It's a diagnostic puzzle with life or death stakes. Is the patient weak because their disease is worse? A myasthenic crisis, meaning they need more drug?
Or are they weak from a drug overdose? A cholinergic crisis, meaning you have to withdraw the drug immediately.
How do you make that call so quickly?
We use a drug called edrophonium. It's very short-acting. Its effect only lasts about 10 to 20 minutes.
The tensilon test?
Right. If, after injection, the patient's muscle strength improves rapidly, you've confirmed myasthenic crisis. You increase their maintenance dose. If the patient's weakness gets worse,
It's a cholinergic crisis.
it's a cholinergic crisis. You withdraw the drug and you give atropine immediately.
That is just a fascinating example of real-time pharmacological testing. So for long-term management, is pyridostigmine the go-to?
It is. Pyridostigmine is a reversible cholinesterase inhibitor, and we use it because its duration of action, 3 to 6 hours, is longer than the others. It just makes dosing schedules much more manageable for chronic care.
Let's move to the second major application, managing Alzheimer's disease.
Alzheimer's disease is a progressive dementia. It's defined by the loss of H-producing neurons and the receptor targets inside the brain's cortex.
The part of the brain linked to memory and association.
Exactly. So since this is a progressive degenerative disease, the goal here is management, not a cure.
You're just trying to slow the slide.
Correct. We use indirect agonists that do cross the blood-brain barrier. Drugs like donepezil, galantamine, and ribostigmine. The goal is to boost HM levels in the cortex.
And that elevation helps slow the progression of the disease.
It does, but it can't reverse the neurological damage that's already been done.
The pharmacokinetics of the prototype, donepezil, seem almost perfectly designed for this patient population.
They really are. Donepezil has this remarkably long half-life of 70 hours. So for a population that's often struggling with memory and adherence, this means it can be given just once a day. It simplifies the entire regimen.
Which is a huge deal for caregivers.
A huge deal. It reduces caregiver burden and the chance of missed doses.
You mentioned an alternative treatment that's sometimes combined with it.
That would be memantine. It's non-cholinergic. It works as an NMDA receptor antagonist.
How does that help?
It works by slowing the neuronal degradation process. It blocks sites that perpetuate damage. It's often packaged right with donepezil in a combination pill called Namzaric. So you're targeting two different parts of the disease at the same time.
Okay, let's switch to the practical takeaways, the safety and teaching points for the healthcare provider. What are the absolute baseline assessments you need before giving these drugs?
Everything related to the PNS.
Yeah.
So a detailed assessment of vital signs, heart rhythm, lung sounds for any sign of bronchospasm, abdominal assessment for bowel sounds because motility is going to increase, and meticulous monitoring of intake and output. And, because of the risk for severe bradycardia, an ECG is often a good idea before you start therapy.
And what must be on hand at all times? No exceptions.
This is the single most critical safety point. Atropine sulfate must always be immediately available. If your patient shows signs of a severe cholinergic reaction pulse dropping fast, profound GI symptoms, atropine is the antidote you need to reverse those effects.
Let's talk about administration timing, because the two classes are different.
It all comes down to GI tolerability. For the direct-acting oral forms like bethanechol, we give them on an empty stomach. That's to minimize the nausea and vomiting.
Which can be severe.
Which can be very severe with that high GI stimulation. Conversely, for the indirect-acting forms for Alzheimer's, like donepezil, we give those with meals. That helps mitigate the generalized GI upset.
Good to know. And what about surgery?
The anesthesiology team has to know. They must be aware of their indirect agonist use because it can dangerously prolong the effects of surgical neuromuscular junction blockers.
Reinforce the critical drug interaction for us. Why are NSAIDs such a major risk with these drugs?
Well, we've already said that cholinergic agonists drastically increase GI secretions and motility. When you combine that with NSAIDs, which are already known to erode the gastric mucosa,
You're just asking for trouble.
you multiply the risk of severe GI bleeding. It's a combination that's either avoided or managed with very aggressive monitoring.
Okay, let's quickly touch on lifespan considerations, the very young and the very old.
Children are just more susceptible to all the adverse effects. Specifically, the increased salivation and diarrhea pose a higher choking and dehydration risk. Dosing has to be strictly weight-based.
And older adults.
Older adults are high risk because of potential liver or kidney impairment, which can lead to rapid toxic drug accumulation. You have to start them on much lower doses and monitor closely for serious complications. Things like arrhythmias or orthostatic hypotension, which could lead to falls.
Let's close with that case study of AJ. He's 75. Starting rivastigmine for Alzheimer's, and he's already having trouble swallowing.
This just highlights the convergence of challenges. First, the teaching. The nurse has to make sure AJ and his family understand that the rivastigmine will only slow the progression. It won't restore memory.
Managing expectations is key.
Absolutely. And then there's the formulation. His dysphagia makes the choice a major safety issue.
Right, he can't swallow capsules.
Exactly. Since rivastigmine comes in capsules, an oral solution, and a transdermal patch, the nurse should immediately advocate for the patch or the solution. You have to prevent aspiration pneumonia.
And the side effects will just complicate things further.
They will. The drug's expected adverse effects, increased salivation, dizziness, incontinence, will just add another layer of complexity to his care and increase the demands on his caregivers.
That really brings the pharmacology right to the bedside. So, to recap, we've covered the molecular imposters, The direct agonists used for the bladder and the eye.
And the enzyme blockers, the indirect agonists, which are crucial for enhancing muscle strength in myasthenia gravis and improving cognition in Alzheimer's.
The key takeaway really seems to be whether they cross the blood-brain barrier.
It is. The ones that stay peripheral, like pyridostigmine, are for muscle. The ones that get into the CNS, like donepezil, are for memory. And, never forget the atropine and pralidoxime protocol.
For me, the lasting insight is that dynamic test in the MG crisis. You have a patient who is struggling to breathe, and the provider has to figure out, right then and there, if the problem requires more drug to live or withdrawal of the drug to live. The speed and accuracy that balance requires, it's the ultimate high-wire act of pharmacology. What stands out to you as the most clinically demanding part of managing this class?
I agree with the MG crisis, but I'd add the constant assessment of the older adult for subclinical overdoses. They might just present with nonspecific confusion or a minor drop in blood pressure, but that could be the very first warning sign of life-threatening toxicity from impaired renal clearance. It demands just heightened vigilance.
That's a powerful final thought. Thank you for guiding us through this challenging but critical deep dive. Until next time, stay well informed.